So, what's really happening with healthcare point solutions? The common story is that point solutions are necessary evils. Prior authorization is too complex to automate, care management requires clinical judgment, navigation needs human empathy. But the reality is more complicated. The reason these solutions exist is actually collapsing, and not in 5 years, but I think this year. I talk to employers, consultants, and point solution vendors every single week, and what I'm hearing is a growing disconnect between what vendors are selling and what employers are actually getting. In this video, I'm going to share three things. First, why point solutions exist in the first place and why the model is already broken, the structural problem that no one really wants to talk about. Second, the 50 to 70% of point solution operations that are automatable right now, including voice AI that's changing customer service and care management just as we speak. And third, what I'm calling platform swallow. Who survives, who gets absorbed, and what it means for your strategy. Let's dive in. Here's why this matters right now. AI health tech investment hit $14 billion in 2025, capturing 62% of all healthcare venture capital. Let me give you some specific examples of what's happening. Open Evidence, the chat GPT for doctors, raised $700 million in less than a year and is now valued at $12 billion. They went from a $3.5 billion valuation in July of 2025 to $12 billion by January 2026. That's not a typo, but it is Dan math. The company more than tripled its valuation in 6 months. Abridge, which uses AI to transcribe patient-provider conversations, raised over $550 million in a rapid sequence of mega rounds. $150 million Series C, $250 million Series D, $300 million Series E, all within 18 months. This isn't theoretical. This is capital flowing into companies that are actively replacing human operations. And here's the thing that jumped out to me. People are already uploading their own medical records to ChatGPT, not because they trust it more than their doctor, but because they can't reach their doctor at 10 p.m. on a Tuesday. In fact, they can't reach their doctor at 10 a.m. on a Tuesday. There's a vacuum in healthcare customer service, and AI is filling it whether the industry likes it or not. Point solutions exist because generalists couldn't do specialist work. A benefits administrator couldn't do what a care manager does. But AI is collapsing that gap, and it changes everything. Before we get into what's broken, let's talk about why these solutions exist in the first place. Because understanding the origin story helps you see why the model is collapsing. Point solutions exist because modern American insurance carriers, United, Cigna, Aetna, Blue Cross, they've largely obviated their responsibility for innovation within the plan. In the past, carriers did this work themselves. They developed utilization management programs. They built care management capabilities. They innovated on disease management and payment integrity. But over the last 15 to 20 years, they've systematically outsourced these functions to point solution vendors. Today, there are over 8,000 HR, wellness, and benefit vendors from across 290 different product categories, according to Shortlister's database. That's the scale of fragmentation we're dealing with. And here's the catch that nobody wants to talk about. This outsourcing hasn't resulted in lower admin fees for employers. Carriers are still charging the same, often escalated admin fees they've always charged. So employers find themselves paying $3 PM for a point solution and paying the same admin fee to the carrier. It's a double payment for what used to be a single function. This also creates massive complexity. These vendor solutions are hard to integrate into existing carrier systems. When integration does happen, it's often clunky. Data flows are fragmented, and employers can't take full advantage of these solutions because incorporating them into their existing workflows is so difficult. These point solutions also generate tremendous amounts of data, but it's unclear to me whether any of this data actually gets integrated into the overall holistic care management and disease mitigation strategies that carriers' employers are already using. In most cases, it doesn't. The data sits in silos, so we've created this incredibly inefficient system. On one hand, there's a massive innovation going into point solution companies. On the other hand, much of this innovation is lost in the lacking of efficiency and implementation and the lack of utilization by the members and employees that it's supposed to benefit. And this brings us to one of the hardest problems in the industry, measuring whether these point solutions actually work. Here's the reality. Many of these point solutions are feeding into a larger system of care, where there are multiple touch points hitting a patient at the same time. A diabetic member might be in a diabetes management program, a care navigation platform, a telehealth service, and getting outreach from the carrier's own care management team themselves, all simultaneously. So when that member's A1C improves or their costs go down, who gets the credit? It's nearly impossible to attribute value to any single point solution actuarially. The methodologies are so different, the baseline so questionable, and the confounding variables so numerous that employers are increasingly tuning out the ROI claims entirely. Let me give you a concrete example. Say you have a population where 10% might have diabetes, prediabetes, or be at risk of prediabetes. Even though this represents 10% of your population, a point solution vendor might only engage 10% of that eligible population on a good engagement plan. That means less than 1% of your employees are actually participating in the program. For that 1%, you've done extensive vendor contracting, implementation work, integration efforts, and ongoing management of the system. It's unclear whether that level of effort produces meaningful impact, particularly on your overall financial health of your company. And this is compounded by how these solutions are paid for. There are two primary ways employers pay for point solutions today, and both have significant problems. First is the PMPM, which stands for per member per month. You pay a flat monthly rate for your entire population, whether they use the service or not. This might be $2 or $3 PMPM across the whole workforce. The advantage is predictable cost. The disadvantage is that it puts the entire burden of engagement with the employer. HR has to drive awareness, communicate the benefit, and try to push participants to participate. And here's the reality. HR teams today, they're anemic. They're stretched thin. They have dozens of other priorities competing for employee attention, including today a huge increase in trend. Benefit communication is just one of the many things that they try to do. So you end up paying full price for a solution that maybe 10% of your eligible employees actually use. The alternative is case rate pricing. You only pay when an employee actually uses the service. Now, this removes the risk from the employer. You're not paying for unused capacity, but case rate creates challenges on the vendor side. The point solution company depends heavily on the employer to drive communication and engagement, and many times they're blocked out. They're not given an employee list. They're only allowed to communicate to employees maybe once or twice a year. They're treated as just another vendor trying to get attention. So the vendor can't control their own destiny. Their revenue depends on the employer's communication, the effectiveness, which is often, frankly, poor. There are some value-based care approaches where vendors take on some risk tied to outcomes, but again, these are incredibly hard to validate within an organization because of the problems that I just described. How do you prove causation when there are 15 other factors affecting the outcome? So let's talk about the structural problem here. Everyone in the industry accepted the same premise. You need specialists for each function. Prior auth is its own world. Care management requires dedicated nurses. Navigation needs trained advocates. So employers started buying these specialized vendors, but the numbers tell a different story. 76% of employees don't understand their own benefits. Only 10% actually utilize the point solutions their employers pay for. 10%. That means 90% of the value that employers are paying for goes unused. And it gets worse. Employers are stacking $3 PMPM solutions on top of roughly $50 in many cases in base admin fees. Let me walk through what a typical employer's point solution stack might look like. Prior authorization service, care management platform, telehealth vendor that's required now, mental health point solutions, MSK or musculoskeletal programs, fertility benefits, advocacy services. That's 7 vendors, 7 contracts, 7 integrations, 7 guaranteed ROI claims that I've set across the table and heard, this is going to give you a 2-to-1 ROI. And every single one of them says the same thing, but nobody believes it anymore. The ROI methodologies are so different, the baseline so questionable, and the attribution so murky that employers are starting to tune it out. Here's the part that most people don't want to hear. 60 to 80% of point solution operating costs are human staff. This is customer service reps, care managers, benefit specialists, outreach coordinators. That's where the cost is, and that's exactly where AI disrupts. Now, the common pushback I hear is AI can do the easy stuff, Dan, but not the real clinical work. Let me break down what point solutions actually do. I'm going to walk through 6 core functions and show you what's already happening with AI in each one of them. Number 1, prior authorization. What it is, getting approval from insurers before procedures. Now, in the traditional model, the staff is submitting forms, they're following up on pending cases, handling denials and appeals. AI reality, Cohere Health is processing over 20 million prior authorization requests with AI, real time eligibility checks, auto submission, appeals drafting. The only human touch point is edge cases, maybe 15% of volume. What this means that $2 PMPM prior auth vendor, their value prop just got commoditized. How about number two, customer service benefits and questions? Now, what this is what's my deductible? Is this provider network? Why was my claim denied? Now, in the traditional model, you had call centers, you had hold times, business hours only. In the AI reality, this is where voice AI is making massive inroads. The AI voice agent market in healthcare is projected to grow at like 38% annually. That's kind of Dan's number, reaching over $12 billion by 2035. Half of U.S. hospitals plan to implement some form of voice AI by 2026, and the efficiency gains are real. Voice AI completes appointment scheduling in about 2.5 to 3 minutes, compared to 6 to 8 minutes for a human operator, a 50% reduction in handling time. Healthcare providers are seeing 30% improvements in administrative efficiency. Companies like Prosper AI just raised $5 million specifically to tackle healthcare's $450 billion admin crisis. And they're doing much of that with voice AI. The quote, I need to talk to a human objection is dying faster than most vendors realize. What this means that advocacy vendor charging $3 PMPM for a call center, their moat is eroding rapidly. Number three, care management and population health. Now, what this is identifying high-risk members for outreach, care coordination, and in the traditional model, nurses would review the claims data, they would make a phone call, schedule appointments. In an AI reality, risk stratification is pure data science. The AI does it better, frankly. Outreach is pattern execution. AI handles the scheduling, the reminders, the follow-ups. The clinical judgment piece, well, that's real, but it's maybe 20% of the actual work. And here's where voice AI gets interesting for care management. We're not just talking about scheduling calls, we're talking about AI agents that can conduct initial outreach, gather information, identify needs, and escalate to human nurses only when clinical judgment is actually needed. Transcarent is already using AI for care navigation. Accolade is embedding AI into their platform. This isn't future state. It's happening right now. What this means is that care management vendors need to become clinical judgment platforms and not outreach platforms. Number four, referral and site selection. Now, what this is helping members find the right provider at the right cost. It's really important and it's very valuable. In the traditional model, you call an advocate, they search a database, they read you options over the phone. In the AI reality, this is just search plus cost comparison plus quality data. Seraph Health has price transparency data. Leapfrog scores can be found online now. AI can synthesize this almost instantly. The member asks, I need a knee replacement in Dallas, Texas, and gets a ranked list with cost estimates, quality scores, and availability in seconds. I actually built an app that could do that on my own computer. What this means, navigation vendors that are just search plus a human concierge, they're in trouble. Number five, provider directories. This is a really fun one. Now, what it is supposed to be accurate, up-to-date provider information. And in the traditional model, these are static databases. They're quarterly updates, and there are constant complaints to the Department of Insurance. In an AI reality, this is pure data management. AI web scraping, real-time verification accuracy scoring. There's no human judgment here. It's just pattern execution. And what this means is that provider data vendors either become AI first or they get absorbed into platforms. Number six, ID cards and enrollment. Now, what this is generating ID cards, processing enrollment changes, eligibility updates. Now, in the traditional model, this was batch processing. Manual exceptions caused incredible delays. But in the AI reality, you can get instant generation, self-service changes, and real-time sync. No human needed, period. And what this means also is that the function is already fully automatable. If your vendor still has humans doing this, you need to ask them why. The pattern across all six, 50 to 70% of these operations are pattern execution. They're not judgment calls. They're not empathy. They're pattern execution. And the technology to automate them already exists today. Here's what changes when AI enters the picture: the ability to do global contact. What I mean is this: a single AI system can do many things at once that previously required separate point solutions. Musculoskeletal referrals and site selection, payment integrity, benefits navigation, prior authorization. These are extremely disparate functions, but theoretically, they could all be handled by a single AI platform. When you remove the human elements of cost, The actual delivery costs could be substantially lower. The question is, who captures that value? Will point solution vendors incorporate these AI solutions and reflect the cost savings back to employers, dramatically improving that ROI? Or will the opposite happen? Vendors become a little more efficient on the delivery, but the profits flow to the point solution vendor while the employer sees no benefit. There's a precedent forming here. KPMG recently negotiated lower fees from its own auditor, Grant Thornton, by arguing that AI makes the work cheaper. They got a 14% reduction. The audit fee dropped from $416,000 to $357,000. The argument was simple. AI creates efficiency, so pass some of those savings back to us. I think this is going to happen across benefit consulting and point solutions. Employers and consultants will start demanding, you're using AI now. Where's my cost reduction? And many point solution vendors won't be able to deliver. Why? Because the vast majority took venture capital to grow. Those investors are expecting returns, and so the pressure to maintain margins will be enormous. This creates a value challenge. There will be disruptors who see that so much of this is automatable and offer dramatically lower pricing. The existing vendors that are weighed down by VC expectations and legacy cost structures and they didn't take advantage of the time that they had will struggle to compete. Now, I want to spend a minute on something that doesn't get enough attention. Consumers are driving AI adoption in healthcare. 7 in 10 consumers already use health technology monthly. Wearables, apps, portables, and they expect to adopt emerging tools like AI-assisted personalized care plans within 5 years. So consumers aren't waiting for the industry to figure this out. But here's the nuance. Consumers are willing to share health data, but they're becoming pickier about who they share it with. The proportion willing to share with doctors dropped from 72% in 2020 to 64% in 2023. That's a drop. On average, consumers are willing to share data with 2.7 entities now versus 3.4 entities in 2020. They're getting pickier. What matters to most consumers? Privacy protections. Consent is the number one factor, followed by deletion, regulatory oversight, and transparency. So we're in this interesting moment in time. Consumers are adopting AI tools faster than many predicted, including me. They're uploading medical records to ChatGPT. They're using AI chatbots to research symptoms. They're taking pictures of x-rays and putting it into Perplexity. But they're also getting more discerning about who gets their data. If you look at historical technology adoption patterns, there are parallels. mHealth adoption followed a progressive trajectory. Cautious exploration at first, then acceleration driven by smartphone penetration and growing acceptance. The same pattern is playing out with AI. The difference is speed. The tools are changing so fast that consumers are having to absorb new capabilities in months and not years. And as they experience value from these tools, their expectations shift. The traditional model of call this number during business hours and wait on hold endlessly becomes increasingly unacceptable. And I'll be honest with you about something. If you asked me 5 years ago or even 2 years ago, I would have told you that humans in the loop talking to patients isn't just beneficial, it's mandatory and it will never change. That's how I was trained to think about healthcare, but I might be wrong about that. Consumers will make that decision, and we may be surprised by what they choose. When you combine aggressive consumer adoption with the AI efficiency gains that AI enables and the cost pressures that employers are facing, you can see where this is heading. The future favors AI-forward point solution vendors that offer incredible value, better and transparent ROI, lower cost to employers, and more efficient delivery. The 8,000 existing benefit vendors, many built on top of call centers and 1990s technology, they're going to be extremely challenged. And who survives this? Here's the origin story of point solutions. Carriers were bad at care navigation, TPAs were bad at advocacy, PBMs were bad at transparency. Platforms couldn't do everything well, so specialized vendors fill these gaps. But here's what's happening now. These platforms are building AI capability, and when they do, they swallow the point solutions. Let me walk you through what this could look like in practice. And I call it the carrier swallow. United Healthcare, Cigna, Aetna, Anthem, they're all investing heavily in AI. Optum, that's United's service arm, backed Guide, which I've talked about previously on my Substack, with $60 million. They're not doing that to help brokers. They're learning how to automate brokerage functions themselves. Cigna bought Evernorth and is building AI into population health. Here's the question employers should be asking. When a carrier can offer AI-powered navigation services, prior authorization, 24/7 member support is part of the base admin fee. Why would you pay $3 PMPM for extra point solutions that does the same thing? The TPA swallow. Third-party administrators serve self-funded employers. Companies like Allegis, Health Equity, WEX, they're building AI into benefits administration. So when the TPA can handle enrollment, ID cards, eligibility, and basic member questions with AI, that's 3 or 4 point solutions that just became redundant. The PBM swallow, well, pharmacy benefit managers are notorious for opacity, but Mark Cuban's Cost Plus Drugs, Amazon Pharmacy, and new transparent PBMs are using AI for drug cost optimization, therapeutic alternatives, member education. The pharmacy advocacy point solution category, that's getting swallowed too. So what survives the swallow? Point solutions survive only if they have something the platforms can't easily replicate. I see 4 categories. One would be proprietary clinical IP. If you've developed genuinely differentiated clinical protocols, not just care management, but specific condition expertise with measurable outcomes, that's defensible. Hinge Health for MSK, Lyra for mental health, they have clinical IP, not just services. 2 would be network effects. If your value increases with scale in ways platforms can't match, Collective Health has network effects in their employer broker ecosystem. Accolade has data network effects across their population health platform. These compound over time. 3 would be regulatory moats. Some functions require specific licenses, certifications, or compliance infrastructure that platforms don't want to build internally. One example would be specialty pharmacy, complex workers' comp. These are defensible because they're hard. 4 would be the speed of innovation. Some point solutions are just faster than platforms. They can ship new features, adapt to regulation changes, and iterate on member experience faster than a carrier ever will. But this is temporary. It's a head start. It's not a moat. So for employers watching this, ask 2 questions when you're evaluating a point solution. First, is your core function something my carrier or TPA should be adding to their platform, and especially with AI? And if the answer is yes, you should expect commoditization. Second, what's your moat? And if they say relationships or service quality, that's not a moat. That's a temporary advantage. So push harder. For point solution vendors watching this, look at your P&L. If 60 to 80% of your costs are human operations, and we're talking customer service, care management outreach, call centers, you have 2 choices. 1, rebuild those with AI before the platforms do. Or 2, get acquired by a platform that will do it for you. The $3 PMPM model only works if your operating costs collapse with AI. Otherwise, you're a feature, not a product, and features, they get swallowed. So let me pull this together. Point solutions exist because carriers outsourced innovation. Over 8,000 vendors now compete for employer attention across 290 product categories. Let that sink in. The market is massively fragmented. The measurement is nearly impossible, and ROI claims have lost all credibility. 50 to 70% of their operations are automatable today, and I walked you through exactly which functions and who's already doing it. Prior authorization, customer service and voice AI, care management, navigation, directories, you heard it. The pattern is clear. The platform swallow is coming. Carriers, TPAs, and PBMs are building AI capability. Point solutions that don't have real moats, we're talking proprietary clinical IP, network effects, or those regulatory barriers, they're all going to get absorbed. And we're seeing the first shots be fired by people like KPMG. The same pressure is coming to every point solution contract. For employers, this is a massive opportunity. Consolidate your point solution stack, demand AI first vendors. The leverage is shifting to you. For vendors, the message is urgent. Rebuild your operations with AI now or become an acquisition target for someone who will. Not in 5 years, not in 3 years, but this year in 2026. The funding is there, and we're talking big funding. And the consumer behavior is already changing here too. People are choosing convenience over tradition, so don't get stuck in tradition. If this was helpful, subscribe for more healthcare AI strategy. And if you want to dive deeper on which vendors are actually building AI capability versus ones which are just talking about it, I've got all this full write-up on my Substack and the links in the description. Thanks for watching. I'll see you in the next one.